Hey, Dr. Sumner. Hopefully you can hear me okay. I'm not sure how they're going to end up recording this and if there's going to be like a video of me or not, but this is the one way I could figure out how to make it work with having my notes here on this side that I could kind of read off of. But I'm also wondering if maybe I just need to put them on like a Word document and then maybe have those on the side and reference them if I need to. But hopefully by the time I record it here, and I'd say about a week, I'll have most of it close to memorized. But anyways, I'll go ahead and start. So thanks everybody for tuning in. So my name is Samuel Burkhardt. I'm currently a rotating intern at the University of Pennsylvania, and my interest is in surgery. And today I'll be presenting on investigating parathyroid morphology. So here's just a simple outline, a breakdown of what I'll be covering. So going over the introduction of just talking about some pathophysiology of the parathyroid, going over our objectives and hypothesis of the reasons kind of we're performing this study, and then of course reviewing our methods, results, some discussion, and then why that's pertinent to us as veterinarians, and then limitations of our study, and of course the final conclusions, and then my references. So to just kind of introduce and really quick refresher on the parathyroid, this is just a very simple diagram to illustrate the role of the parathyroid and parathyroid hormone. Just kind of putting aside the relationship this hormone has with cholecalciferol and calcitonin, but normally parathyroid hormone causes stimulation of renal tubular and intestinal calcium resorption and osteoclast-mediated bone resorption, which results in increased ionized calcium levels, and of course this is sort of resulting back in a negative feedback loop, which ultimately should decrease parathyroid hormone secretion. So then in cases, where we're trying to diagnose a primary hyperparathyroidism where this sort of feedback loop is getting messed up, is we use cervical ultrasound as the current gold standard. And this is kind of playing a twofold role for diagnosis and surgical planning. And then we're finding that parathyroidectomy as a treatment for primary hyperparathyroidism has proven to have an excellent cure rate of approximately 95%. There are other techniques as well, so there's minimally invasive techniques for primary hyperparathyroidism, such as ultrasound-guided ablation with radiofrequency heat application or ethanol, to provide an attractive option for treatment, especially since they're minimally invasive. However, these techniques have reported failure rates of up to 31% and 28% respectively in some studies. In addition, the potential for metastasis or more invasive pathology with a parathyroid carcinoma may make ultrasound-guided ablation less desirable than a surgical resection that could be, potentially more curative in those cases. So then this leads us to what are our objectives, hypotheses, or reason for performing our study today. So when looking at agreement between ultrasound and surgical findings, they're often inconsistent in previous studies, despite ultrasound being this gold standard for diagnosis and surgical planning. Disagreement between the laterality of a lesion has been reported at up to 19%. So an objective of this study was to assess the agreement between ultrasound surgery as well as histopathology when making a diagnosis of abnormal parathyroid morphology. In addition, previous studies have sought to utilize ultrasound to establish a size range for differentiating between a hyperplastic parathyroid gland, whether that was an adenoma, versus a parathyroid carcinoma, but they failed to establish sufficiently reliable cutoff values. Therefore, we also wanted to establish an ultrasonographic cutoff value for separating malignant from benign pathology. We hypothesized that parathyroid carcinomas are larger than parathyroid adenomas and hyperplastic parathyroid glands when measured on ultrasound. And then finally, there has been inconsistent results regarding preoperative variables that affect postoperative hypocalcemia. So we wanted to try and provide additional clarity to this debate with the results of our study using the data that we had already collected. So in total, for our methods, we had 47 cases that we collected from the Cornell University Hospital for Animals database from June 2007 to June 2019. 34 of these cases were retrospective and 13 were prospective. We explored method agreements using Cohen's kappa statistic. We also used a nominal logistic regression analysis used to generate a receiver operating curve for the cutoff of differentiating between parathyroid adenoma and hyperplastic parathyroids versus a parathyroid carcinoma. And then we used univariable screening to explore associations between development of postoperative hypocalcemia and all exposure variables of interest. And then we also used a multivariable logistic regression with backward stepwise elimination until all remaining variables in the multivariable model reached a p-value of less than 0.1. And from some of that information, we were able to, generate here some good results. So ultrasound agreed with surgery 79.2% of the time, and then surgery agreed with histopathology in 78.5% of parathyroid glands. Found that complete agreement between ultrasound surgery and histopathology regarding the number of affected glands occurred in 26 out of 47 cases, which is essentially equivalent to 55%. And interestingly, we also found that in 11 out of 47 cases, which is 23% of the time, at least some of the tissue removed at surgery that we thought to be pathologic, which was the reason we took it in the first place, was not consistent with a cause for primary hyperparathyroidism on histopathology. And then when trying to establish a cutoff value, again differentiating between more benign pathology versus malignant, a receiving operating curve showed a high area under the curve of 0.82, at which 0.5 out of 7, or 71.4% of carcinomas, and 39 out of 44, or 88.6% of adenomas or hypoplasia were actually correctly identified based on size alone. So we were able to generate some sort of cutoff for these values, which I'll speak to more later. And then finally, looking at that last objective of trying to identify preoperative variables that could affect the likelihood of postoperative hypocalcemia, we found that there was a significant positive association with having a preoperative ionized calcium greater than or equal to 1.75 milliequivalents per liter, and then developing a postoperative hypocalcemia. We actually were able to establish a p-value of less than 0.05. In addition, perhaps most importantly for us as clinicians, prophylactic supplementation with calcitriol or calcium was not associated with the development of postoperative hypocalcemia. And we saw even at our own hospital, we were using these medications prophylactically in a number of cases, and just based off previous studies, and they didn't seem to have any added benefit. In addition, you can see that there's plenty of other variables here that didn't really have an effect. In addition, like the length of the clinical signs before hypocalcemia onset, the length of previously documented hypercalcemia prior to surgery, as well as the parathyroid hormone index, phosphorus, calcium versus phosphorus, and then the maximal dimension of the nodule that we found on ultrasound. And then a couple other interesting statistics that we were able to pull from some of this information was that we found that 22 out of 47, or 46.8% of cases became subclinically hypocalcemic at a median of 48 days, and that 8 out of 47, or 17%, became clinically hypocalcemic at a median of 5 days. So there was a long break of time before they even developed this clinical or even subclinical hypocalcemia. And then, of course, for completeness, we also tested these same variables of interest against the development of laboratory hypocalcemia, to which you can see for all those same variables that we were testing for clinical hypocalcemia, there was really no statistical significance. So then kind of bringing all this together in terms of the agreement part of it, again looking at surgery, ultrasound, and histopathology, there was a fair agreement between ultrasound and surgery with a kappa value of 0.4 regarding identity of the parathyroid pathology. We found, or ultimately concluded, that despite its superiority to ultrasound, cervical exploration is really still lacking in its capabilities as a diagnostic tool, with a 23% rate of removal of non-pathological parathyroid tissue, as I mentioned before. The results of this study are showing that ultrasound is only a moderately reliable tool in evaluating parathyroid pathology, indicating the importance of the bilateral parathyroid exploration in dogs with a primary hyperparathyroidism. In contrast, when looking perhaps at human medicine, the trend towards minimally invasive surgery in humans has necessitated the use of more accurate diagnostic techniques, and this was an interesting rabbit hole to kind of go down, was what they're using in human medicines, including nuclear medicine scintigraphy and four-dimensional CT, in concert with intraoperative parathyroid hormone monitoring during surgery to minimize unnecessary surgical resection. Further research, is warranted to determine if a similar diagnostic approach could improve the identification and removal of pathologic parathyroid tissue. And perhaps most importantly, in veterinary medicine, is this going to also remain cost-effective at the same time? And then in terms of a cutoff, we were able to establish with our receiver operating curve and the area under the curve that there could be a reliable cutoff value of greater than or equal to 8 millimeters as measured by ultrasound for identifying with some statistical significance that it was a parathyroid carcinoma. Although, we're still going to express caution here that, we should exercise caution in using size as the sole criteria for diagnosing carcinomas. Identification of a large parathyroid mass may give timelines for surgery given the theoretical risk of metastasis and invasiveness of a more aggressive, carcinoma versus an adenoma or hyperplasia. And then when looking at our postoperative hypocalcemia and variables that are going to affect that, just kind of reflecting on what I said before, so greater than or equal to 1.75 for an ionized calcium would be more indicative of potentially developing a postoperative clinical hypocalcemia. We're not endorsing this as a strict cutoff, but this does, when you have a PET with this sort of value, it potentially is supporting more vigilant monitoring for a postoperative hypocalcemia in these dogs. And then, they should be closely monitored postoperatively considering their increased risk of developing hypocalcemia. And that was the main point we were kind of drawing from that. And, alternatively, again, kind of finding other things that weren't causing this postoperative hypocalcemia and drawing from that was that, administration of prophylactic calcium supplementation, removal of those sort of treatments because they don't really seem to have any effect or association with developing a postoperative hypocalcemia or providing a protective effect against it. Eliminating these treatments would, potentially eliminate an unnecessary cost for the client, as well as eliminating the suppression of the non-pathologic parathyroid glands that could potentially be occurring with administering these treatments prophylactically. There were several limitations to our study that we're cognizant of. So there's some, of course, subjective variability in the assessment of the parathyroids, as there were several different boarded radiologists, surgeons, and pathologists who participated in the workup of these cases regarding the ultrasound, the surgery, and the histopathology of them. And there was, of course, some inherent case selection bias, as 33 cases in this study were examined retrospectively, and the number of cases included in this study was small, which is reflective of the low incidence of primary hyperparathyroidism. So in conclusion, just again reflecting on the most important parts of this study and the most important conclusions, a preoperative ionized calcium greater than or equal to 1.75 is a significant variable associated with postoperative hypocalcemia in dogs undergoing surgical treatment for primary hyperparathyroidism. These dogs really should be closely monitored postoperatively, considering their increased risk of developing clinical hypocalcemia. Clinicians should be mindful. A lot of these patients that we're doing parathyroidectomies on were discharging a few days or even a day after surgery. But clinicians should be mindful that clinical hypocalcemia wasn't developing until a median of 5 days postoperatively. So we would encourage diligent follow-up with these cases. In addition to all that, we didn't find any other variables that seemed to influence the development of postoperative hypocalcemia. And then we also found that parathyroid carcinomas are more likely to measure greater than or equal to 8 millimeters on an ultrasound. And considering the malignancy of this pathology and the more invasiveness and potential risk for metastasis, we would encourage their surgical removal a little bit more urgently than if you measured on an ultrasound a parathyroid gland measuring less than this size. And then we also determined that ultrasound is only a moderately reliable tool in evaluating parathyroid pathology, and while it provides, is an extra instrument for surgical planning and identifying the size of the gland, the importance of the bilateral parathyroid exploration in dogs with primary hyperparathyroidism cannot be understated. And we would really encourage, here in the future, looking forward, that prospective studies instead of a retrospective study combined with a prospective study, one that is also multi-institutional versus just one, would allow for a larger case selection and would be useful to further investigate ways to increase the efficacy of parathyroidectomies, as well as identifying variables that could influence postoperative hypocalcemia. Here's some of my selected references, and if you guys have any questions or anything like that, please feel free to reach out. My email is sjburke@upenn.edu. I'd be happy to hear from you all. Thank you so much for listening.